Hello, everyone, and thank you for joining us for our clinical webinar today. My name is Dr. Savannah Clary, and I'm a member of the Aegis clinical team. I will be presenting today's webinar. If you would, please make sure your phones are on mute to help minimize any background noise during the presentation. We appreciate your ongoing participation in these webinars that have been provided by Aegis, and I hope you've learned a lot over the past couple of months about our novel psychoactive substances testing, or NPS testing, as I will refer to it throughout the presentation today. Our takeaways for today will include a brief review of NPS testing offered by Aegis and the background on NPS drugs as an increasing threat, a report of NPS drugs identified thus far in specimens tested by Aegis, a discussion of co-positive substances using example reports, and an overview of NPS usage, risks, and effects. Those who missed the live presentation this afternoon or who would like to hear it again may find a recording of this presentation on the Aegis website. That's www.aegislabs.com. Please contact client services at 1-800-533-7052 if you need assistance in accessing this recording. Aegis launched an extensive and industry-leading testing menu of NPS drugs in July of 2020, and this includes designer benzodiazepines, designer opioids, synthetic cannabinoids, and synthetic stimulants. These classes of NPS testing are ordered individually according to the clinician's assessment of medical necessity. When a class is ordered, all of the NPS drugs within that class are tested. Here are the drugs that are tested within each NPS class. These drugs have been carefully chosen based on information from the CDC and the DEA regarding drug use trends, overall statistics on overdose, crime-related seizures, and that sort of information. We will continue to evaluate the drugs that are included in our NPS testing on an ongoing basis to ensure that we are best aligning our offering with the available usage data that is out there. Some clinicians may be unaware of how patients can access these drugs or if usage is really a concern for their patient population. The fairly easy access that people have to these drugs facilitates their unregulated and often undetected use. It's not hard to find discussion of these substances among users in internet forums and even social media in some cases. When advertising online, sellers may use phrases such as research chemicals or not for human consumption to try and evade regulation. The primary means by which many of the designer opioids and benzodiazepines have reached the street have been related to either failed or abandoned attempts to bring a new drug to market, and then further modification of that drug by chemists in order to circumvent any regulatory efforts. People may be attracted to the presumed opportunity for a, quote, legal high, as it is sometimes referenced, and they may even recall when synthetic cannabinoids and bath salts were widely available in gas stations and convenience stores. In the mid-2000s, synthetic cannabinoids became more prominent. This was closely followed by the bath salts, as well as the non-caffeinone stimulants. And then designer benzodiazepines and opioids began to be reported by the DEA around 2014 to 2015. We do have additional information available on our website regarding the background, evolution, and accessibility of these NPS drugs, including 3 clinical update articles. Those are shown on your screen there. Additional recorded webinars will also be added to our website for more information on this topic, but we're going to switch gears now and talk a little bit more about the observed positive results for these drugs and possible scenarios for exposure as well as clinical effects. There's been quite a lot of interest in NPS testing from pain management, addiction treatment, and behavioral health providers, just to name a few. Considering the relatively easy access to these drugs by the general public, we were very interested to see which drugs would be detected first and most often as the results began to report. We have had positive results across all 4 classes of NPS drugs for which we offer testing. A few highlights on these drugs. The designer benzodiazepines that we've detected were the top 4 most identified designer benzos in the 2019 and 2020 DEA emerging threat reports. Valeryl fentanyl was one of the more frequently identified fentanyl analogs on these same reports. The synthetic cannabinoids were also among the most common noted by the DEA. And Eudalone was the most identified synthetic cathinone on the DEA emerging threat reports in 2019 and 2020 as well. Another interesting aspect of this data is to examine what additional substances were detected along with the NPS. In this case, the sample contained multiple designer benzodiazepines. There was clonazepam, atezolizumab, and flualprazolam. And on an Aegis report, the medication compliance box would show the overall positive results for the designer benzodiazepines, and then the detail of each drug that was detected would be found below that medication compliance box in the test requested content section of the report. The additional detail of the other drugs tested has been omitted from this example just so we can focus on the NPS results. So what might be some ways that the patient could have been exposed to these drugs? Well, it could have been an intentional exposure. As we discussed already, these drugs are fairly easily accessible. The patient could have easily purchased them intentionally for use. There's also the possibility that these drugs were combined into counterfeit benzodiazepine tablets. This has been described in the literature in which individuals thought they were purchasing a brand name drug like Xanax, even having the word Xanax pressed into the tablet, only to find out later in the course of receiving emergency medical care that the tablets actually contained a designer benzodiazepine. The drug may also have been laced into the other illicit drugs that were detected, such as the cocaine or the marijuana. So on this case, there's a lot of information here in this sample, starting with just the sheer number of co-positive substances. The buprenorphine was prescribed in this case, but the other prescription drugs were not marked as prescribed on the requisition. So in addition to the designer opioids, the sample also contained fentanyl and morphine. There are possible prescription explanations for both of these drugs, but when they are both detected and not prescribed, it can be a red flag for possible heroin use. Neither parent heroin or 6-monoacetyl morphine were detected, so we cannot say definitively that heroin was used just based on these results. However, the period of detection for those markers I just mentioned, the heroin and the 6-monoacetyl morphine, is about 24 hours in urine. So those markers may have already degraded and metabolized into morphine. Fentanyl and counterfeit fentanyl and fentanyl analogs are often cut into heroin as well. So that's where the fentanyl and Valeryl fentanyl may be coming from. This sample also underwent the drug-drug interaction testing, and quinine was detected. Quinine is a common adulterant in heroin, just as one possible source of exposure. If the Valeryl fentanyl was laced into another drug the patient used, the amount and the relative potency could have been unknown to the user. Depending on this person's tolerance and the amount that was ingested, this very easily could have been fatal. This type of contextual information learned from reviewing the results and the possible scenarios helps a clinician further expand the clinical picture and gives additional information about the patient's level of risk. We talked about the term quote-unquote legal high earlier, and between that notion and some of these possible effects, it's realistic to believe that some patients could be seeking these drugs. These substances typically go undetected on most drug testing, so they provide an opportunity for the user to potentially experience the desired effects and possibly avoid additional consequences, such as losing access to their prescription drugs. Designer benzodiazepines can have a calming effect. The designer opioids may also provide a sense of euphoria and relaxation, along with analgesia. Synthetic cannabinoids can create a feeling of relaxation. Synthetic stimulants can create the urge to move and be more talkative. They may also enhance concentration and provide a sense of euphoria and emotional openness. These effects are in no way proven with clinical data, but user anecdotes shared among people and online can be powerful influences. The full spectrum of effects cannot ever be fully anticipated or calculated, and it's important to also discuss and be aware of the possible adverse effects associated with the use of these drugs. In a prescription drug setting, adverse effects have largely been studied through clinical trials and post-marketing surveillance to help ensure that providers are aware of the safest way to prescribe these drugs and what to watch out for in the event of adverse effects. In the case of NPS and designer drugs, predictability is not something that a user can count on. All of the NPS classes carry significant risk of adverse effects up to and including death. Designer benzodiazepines can cause confusion, lethargy, respiratory depression. Withdrawal effects are also possible, including severe anxiety, insomnia, and seizures. Designer opioids can cause sedation, nausea and vomiting, and respiratory depression. They are highly physically addictive with a high overdose potential. Adverse psychiatric effects such as confusion and delirium are also possible. Synthetic cannabinoids can cause an acute psychosis and dangerous cardiovascular effects. Nausea, vomiting, chest pain, and dyspnea are all possible, along with a hangover state that is not typically seen with traditional cannabis. Synthetic stimulants can also cause an acute psychosis and dangerous cardiovascular effects. Hyperthermia, chest pain, headache, bruxism, seizures, and serotonin syndrome are all possible. The risk of serotonin syndrome is further increased if the user also takes other serotonin-increasing drugs. These drugs are also very addictive. There's no way for a user to take a calculated approach in using these substances. The potency and adverse effect potential cannot be fully predicted, and users take an enormous risk by ingesting any one of these alone, and even a greater risk in combining them with other NPS or illicit or prescription drugs. Case reports of patient exposure to some of these substances have been described in literature. Interestingly, a liquid chromatography tandem mass spectrometry analysis of wastewater samples in Southern Australia, which was collected over the Christmas to New Year period when recreational drug use tends to be high, revealed the presence of multiple types of NPS in the wastewater. There are also numerous reports of these drugs being used by people who came to the emergency department for treatment after use. One patient was treated in the emergency department after administering a nasal spray that he purchased from a local drug trafficker. He later said it was a fentanyl research chemical. He required CPR, naloxone, oxygen, and monitoring in the intensive care unit. Another case involved 6 high school students who took a free sample of something called Hulk that they received from another student. They thought they were taking Xanax. All of the students recovered, fortunately. One suffered from respiratory depression. Most were lethargic and had slurred speech. And one of the teams was able to produce a tablet fragment from what they had taken, and that was analyzed and found to contain flualprazolam. Synthetic cannabinoids have also sent patients to the emergency room. In an ongoing study looking at recreational drug users, 18 out of 179 patients who presented over a 6-month period with acute recreational drug toxicity were found to have synthetic cannabinoids in their system. 7 patient samples contained 1 synthetic cannabinoid, 8 of the samples contained 2 synthetic cannabinoids, and 3 samples actually contained 3 synthetic cannabinoids. The combined effects of some substances can be fatal, as was the outcome in a case published in June 2020. A person was found deceased in their home near a bag of pills with the imprint Xanax on them and a glass containing a dried white crystalline substance. A postmortem analysis determined that actually lethal concentrations of atezolam and caffeine were present. There is a risk of dangerous, if not fatal, outcomes with other combinations of uppers and downers as well. Consider the possible effects of combining prescription amphetamines and designer benzodiazepines, or synthetic stimulants and prescription opiates. These possibilities reinforce the role of monitoring for combined use of NPS and prescription or other illicit drugs in patients who clinicians determine to be at risk for this type of behavior. Recreational chemists will continue to evolve existing NPS substances in efforts to evade detection, and they will continue to create new compounds. Aegis will continue to monitor the DEA emerging threat reports for evidence of new drugs and adapt our testing moving forward to make every effort to keep up with changes in NPS use trends. As more information becomes available about the use of NPS, drug testing guidelines may change to be more inclusive of recommendations related to these drugs. Clinicians have an opportunity to use NPS drug testing results to assess their patients' overall risk and hopefully make positive interventions to help patients stay on track with their care plans. Before we wrap up, I want to tell you how to get in touch with us for additional clinical support. We are ready and willing to take your calls and emails about today's content or any other questions that you may have about result interpretation or drug testing in general. Are there any questions before we conclude today's webinar? You're welcome to take yourself off mute and ask one if you do. I want to be respectful of everyone's time this afternoon. I thank you again for joining us today. Have a great day. Bye-bye.